Good morning, everyone. My name is Dr. Val Montessori, and I'm the Director of Clinical Education at the BC Centre for Excellence in HIV/AIDS. Welcome to Chapter 2 of the BC Centre for Excellence Anniversary Conversation Series. This year marks 30 years since creation of the BC Centre for Excellence, and the aim of these events is to celebrate and commemorate the journey and the accomplishments of the community advocates, researchers, and healthcare providers that have worked to turn the tide of HIV in British Columbia. Today's session is titled The Early HAART Era, A Turning Point in HIV Care. We're very fortunate today to have two amazing presenters. Dr. Sylvia Guillemi is a clinical professor in the Department of Family Practice, Faculty of Medicine at UBC, and a clinical advisor for the BC Centre for Excellence in HIV/AIDS. She's a member of the BC-CfE Committee for Drug Evaluation and Treatment and the Clinical Guidelines Committee. Her clinical and research work focuses on the treatment and management of people living with HIV. And Dr. Marianne Harris is a family physician who has worked for many years in the clinical research program of the BC-CfE. She's also the chair of the Post-Exposure Prophylaxis Committee, and her main research includes HIV clinical trials and complications of antiretroviral therapy. Now, before we start, I'd like to take a moment to acknowledge with gratitude that our place of worship is on the traditional, ancestral, and unceded territories of the Coast Salish Nation, the lands of the Musqueam, Squamish, and Tsleil-Waututh. This acknowledgement is a reminder of the discriminatory, racist, and colonial practices that have had a lasting legacy and continue to create barriers for Indigenous people in our healthcare system. If you have questions or comments at any point during the webinar, please type them into the chat box on the right of your screen. We will take these questions and comments and address them following the presentation. And as we did during our last anniversary session, following the presentation, I'll be joining our speakers for a conversation about their experiences of treating HIV during this time and moderating the questions from the audience. If you're listening to the webinar by phone or you have additional questions and we don't manage to get to them in time, please email them to us at education@bccfe.ca. And we also encourage you to complete the evaluation form for the webinar that will be sent to you in a follow-up email. These evaluations really help us to improve our programming. They're very useful, so we'd really very much appreciate that. Now, before we start, I'd like to acknowledge the BC-CfE communications team as well as the clinical education team and the IT team, all of whom are integral to being able to put these sessions forward. As far as disclosures are concerned, Dr. Guillemi has participated in advisory board meetings and received honoraria from Gilead Sciences as well as ViiV Healthcare. And Dr. Harris also has participated in advisory board meetings and received honoraria and consulting fees from Gilead Science Canada as well as Merck Canada and ViiV Healthcare. This program has not received any financial funding or in-kind support, and the content of the presentation has been developed by the speakers. And with that, I will hand over the presentation to Dr. Guillemi.
Well, thanks, Val, for this kind introduction, and hello, everyone. Nice to be here again. As Val said, I've been working at the centers now for many, many years, and also been involved in the care of people living with HIV. I'd like to start my presentation by going way back on the pre-HAART era. And what you see in there was the original first therapeutic guidelines that the BC-CfE released in 1993. I want to highlight the table of contents of these the guidelines, and you can see there, chapter 1 was the antiretroviral therapy chapter. It was a tiny chapter of 2 pages. The rest of the content of these guidelines were mainly focusing on the management of opportunistic infections, which was what was the problem at the time. When you look at the guidelines in terms of the treatments, there were only very few treatments, and I just want to clear my, can I close here? No, I guess no. Anyways, just cover a little bit.
Yeah, just click on the slide.
on the slide? Okay. Oh, sorry, no. But anyways, what you can see there is ACT was the main drug of choice at the time. And then we have combination therapy of two drugs, either ACT with DDC or ACT with DDI. And many of you may not know what I'm talking about. Some others really know very well. These were the first drugs that were available to us at the time. And that was actually, we felt very good that we have at least some type of treatment back then. Now then we move forward and we end up in the AIDS conference in 1996. This was quite a key event and turning event in terms of the management of people with HIV. You can see in the center the picture, that was the logo for this conference done by Joe Average. And in the left, I wanted to highlight the efforts and the work of all the advocates and AIDS organizations that were really pressuring the community, the pharma, and us, the providers, in improving the treatment for people living with HIV. Sometimes was a bit rough, as you can see in the bottom of the slide here, where two of the main participants in the conference, Dr. Bolverdine and Dr. Margaret Fisher, were splashed with a liquid that looks like blood. We were in that event that was kind of traumatic, but really brought home the point that we needed to move forward and bring important changes for helping people living with AIDS. On the other side of the slide, I'm showing some of the pioneers in this movement. Of course, there was Dr. Peter Gibson-Yan, who was a physician that had AIDS and created a diary that was in CBC. And now we certainly are very lucky to have the Dr. Peters Center where patients can attend. Other specialists and primary care providers are in these pictures, particularly Dr. Montaner, who was our lead in the program, and other specialists that were on the front line, like Dr. Lindsay Lawson, you see in the bottom, of course, Peter Phillips, and many others that have been in the front line for the fight of this disease. And some of the primary care providers are the late Dr. Willoughby, who was really involved early in the care of these patients. Fortunately, after that conference, we had a lot of new information, and you can see two key studies. One was the INCAS trial that Dr. Montaner was the main author of these studies, and Marianne, I know, was involved as well, where they showed that the 3 drugs were better than 2 drugs. In this case was ACT, DDI, and nevirapine that showed a significant decrease in the plasma viral load. Another important study that was presented in this conference was the one that Dr. Gulick from New York introduced, which was the combination of ACT, 3TC, and indinavir, again showing much better viral suppression than 2 drugs at the time. In the left of this slide is also another important concept that came through the conference, and was the combination of CD4s and viral loads in terms of progressions to AIDS. As you can see here, those people that had the highest viral load shown in the in the bottom axis, combined with very low CD4s in red, had the worst outcome at 3 years, while those that have lower viral load and higher CD4 counts have best outcomes. And those were sort of important pieces of information that help us to move forward. Fortunately, after the initiation of HAART, we started to see the decline in the number of AIDS cases in BC, shown in the left of the slide here. Over 80% decrease of AIDS cases in BC through the years, and this slide goes up to 2010, as well as increase in the life expectancy and decrease in the number of deaths. So certainly, this had a huge impact in survival for patients living with HIV. I wanted to go back a little bit about what we do here, which is looking at the recommendations and guidelines for initiation of antiretroviral therapy. And this complex slide has 2 pictures. One in the left shows a graph of the progression of the different guidelines, international guidelines, the DHHS, WHO, and the European guidelines, which usually give us some hint, and the center's guidelines follow some of those recommendations as well. And as you can see here, there was a variation of the recommendations in terms of when to start antiretrovirals. For example, earlier in the epidemic, it was advised that we started antiretrovirals with a CD4 count of around 350 to 500. Later, and I'm going to explain that more in detail, there was advice that we started with antiretroviral treatment when patients were closer to the 200 or if they were symptomatic. And with time, we eventually got to the conclusion that actually it's better to start antiretrovirals above 500 CD4 counts. The same is shown in the table next to it with the different time frames, and you can see how you would treat anyone that any time that have a very low CD4 count or were symptomatic, but only later until the last decade we started to treat everyone that presented with HIV infection. Now things have varied because despite that we have access to HAART or combined antiretroviral therapy, there were issues with poor adherence and toxicity. This particular European study called the ICONA study back in the late 1990s showed that approximately 60% of the patients were discontinuing treatment due to toxicity. Well, another large number, 14%, were stopping treatment because they were having virological failure, and again 20% because of poor adherence. So obviously this was very challenging. We also knew that the antiretroviral therapy was effective, but it was not 100% effective. You can see this collection of multiple clinical trials that were in the late 90s, early 2000s, where they showed that only 65%, there was only a 65% response of viral suppression on, with all these different antiretroviral combinations. So certainly the drugs were working, but they were not that effective. Just for your reference, now most of the newer studies or clinical trials they are done, they show a response of over 90%. So these, at the time we were very excited when we were saying 65, 70%, but really we can do way better now than then. So what happened? Well, this, I know this is a complex slide and I will walk you through that. You can see the top of the slide we're reflecting the CD4 counts and plasma viral load results. The second part of the slide shows the different antiretroviral treatments that were given to patients with different colors according to the different classes. And the bottom shows the different genotypes of virtual phenotype history of this particular patient. This is data that we obtained through the drug treatment program at the centers. It's very exclusive, I would say. Not every province has this archive information, but it's very useful in terms of managing the patients. And you can see here, this is reflecting what was going at the time. Patients were using multiple drugs with very little effect in the viral load. You can see hardly we have a detectable, undetectable viral load here, but also developing a lot of resistance to the different antiretroviral therapy. These particular patients have a multi-drug failure, and it was very challenging to treat patients like that at the time. Then again here the BC centers and Dr. Montana and others came up with a multi-drug rescue therapy, which was a combination of drugs. There were a lot of medications that patients had to take, and you can see in the table next to here shows the different type of combination of antiretrovirals that were used in these patients. But due to that, many patients survived and sustained viral suppression, despite that they were previously heavily treated and had resistance phenotypes. So this was a way to move forward to rescue these patients that were having virological failures. Despite that, there was an era between 2001 and 2006 where there was advice to do interruption of therapy. This was recommended for people that had CD4 counts that never were below 250. And they also advised that we continue to monitor the CD4 counts very closely and restart therapy if at any point were below 250 or the patients were symptomatic. Why we had that strategy? Well, the rationale was that there was many antiretroviral therapies that affected the quality of life of the patients. The side effects, short and long term, were significant, and sure Marianne will talk more about that. And then there were concerns about limitations of future treatment options with potential resistance and due to poor compliance. Hopefully that changed, because then we got new drugs that were better tolerated, and we noticed that the balance had changed, so the scale changed to the other side. We knew now that there was harmful effects for having uncontrolled viremia regardless of the CD4 counts because of ongoing inflammation and other issues. The treatment increased, the potency of the treatments increased, the drugs were better tolerated, and patients were able to maintain good adherence, and it was a decrease in the incidence of resistance, which is what we're seeing now. There were many studies that supported the early initiation of antiretroviral therapy, and this is in the early 2000s. One of them is the START study that showed that patients that were receiving treatment immediately had less non-serious non-ACE events. There was the Temprano study, another important study that showed that, again, early initiation of antiretroviral therapy defer improved survival and also decreased comorbidities. And finally, we also had the HPTN 052 study, the famous study that showed that actually people that were treated with HIV would not transmit to their partners. So all of those studies together brought us to the point where we are now, which is the early initiation of antiretroviral therapy with much better tolerated drugs. So just to complete my little piece of talk, I want to conclude here showing this slide that represents the survival expectations or for people living with HIV that receive treatment. And as you can see in the early little people here, if you were receiving antiretroviral therapy in the early eras in 1995 or so, and you were at the age of 20, your life expectation was only 8 years at the time. Moving forward, closer to now, people almost have normal life expectancy if they initiate antiretroviral therapy immediately at an early age. So this, I think, is a very positive outcome. So just I want to acknowledge all the people living with HIV and the advocates that encourage us to keep working hard. And I really want to, I wanted to bring this to this conversation because you are part of the story as well. Of course, Julio and Dr. Montana, who's been leading us through all this journey, and also I borrowed some slides from him, so I need to acknowledge that. Marianne, also I borrowed some slides for her, and we've been working together on this. Kathy, that helped me to put, Dr. Kathy Pascas helped me to put these slides together. And of course, Val and the BC-CfE Education and Communications team. Thank you very much.
Thank you, Sylvia. Mm-hmm. Now we're going to hear from Dr. Harris and slightly different information about the early, mid days.
Thank you, yes, Val, and thanks very much, Sylvia, for setting the stage so nicely. That was a fantastic review of the period. And I'll keep my comments pretty short because I'm sure we're all looking forward to having a conversation at the end, although perhaps there should be some Kleenex on the table.
Yes,
if it's
I needed that last time.
Anything like last time. Anyway, as Sylvia described, it was a very hopeful period during that sort of turning point after the 1996 AIDS conference, but it wasn't entirely smooth sailing, and there certainly were some challenges that we had to face. So I'm just going to, again, touch on those pretty briefly. As Sylvia mentioned, the standard of therapy for HIV and AIDS after the 1996 conference became triple antiviral therapy. which was great. It worked incredibly well. But even in the simplest cases, even the most simple 3-drug treatments involved taking a lot of pills, sometimes several times a day, sometimes food restrictions. So they were pretty complicated for people to take, and took a lot of dedication on the part of people living with HIV to take these medications properly. And certainly it came with other challenges as well. And I took this image from a paper that was written by Dr. Montessori and some of our other colleagues here at the center that was published in the Canadian Medical Association Journal in, I believe, 2004. And you don't need to see the details, but basically this was an article about the adverse events of the antiretroviral therapies that we were currently using. And as you can see, the side effects really covered all bodies, all organs in the body, and literally went from head to toe, with ingrown toenails being shown on this picture. Remember that? So a large number of side effects affecting all kinds of the body that could happen even with the simplest of these regimens. And just as an example, some of these side effects were acute and short-term, or happened very early on in treatment, and one of these was rash. So for example, nevirapine, which was the 3rd drug used in the INCA study that was also widely used here in BC, caused a rash in something like 1 in 6 of people who started this medication, and it usually happened early on within the first couple of weeks of therapy. Rash, not so bad, sometimes it went away, but in a smaller fraction of those patients, they had very serious rashes with things like sores in the mouth and fever, and so it was something that really was problematic for people when they started this medication. Another acute sort of side effect that we contended with quite a lot in the early days was kidney stones. And these pictures are very pretty, but they're not so pretty when you consider that this is Indinavir, the other medication that Sylvia mentioned, which was one of the first protease inhibitor drugs. This is what Indinavir looks like when it crystallizes out in the urinary tract of a person who is taking it. And as you can imagine, these sharp little needle-like crystals damage the urinary tract and the kidneys, and also they can clump together and form kidney stones, which, as anyone knows who has ever had them, are extremely painful and not a pleasant thing to have. And in fact, kidney stones happened in about 1 in 10 people who took Indinavir, despite the fact that they were recommended to drink at least 2 liters of water per day. It's a lot of water. If you think about it, we were asking people to drink a lot of water as well as taking all these medications. And about 1 out of every 10 people who started this medication had to stop it because of kidney stones. On the other end of the spectrum, there were side effects that happened when people had been taking the medications for a longer period of time. And in fact, we often didn't even recognize that these were a problem until these drugs have been available for many years. And one of those that was really predominant then was this lipid dystrophy syndrome, which was associated with abnormal accumulation of fat in some areas of the body and loss of fat in other areas of the body. And this was, unpleasant and disfiguring and also stigmatizing for people who were otherwise well and taking their HIV medication as required. We have Kleenex, so that's the good news I have for our conversation period. As well as being stigmatizing and disfiguring and unpleasant, this lipid dystrophy syndrome was also associated with some serious medical issues, including high cholesterol and triglycerides. And as you can see from the slide, it was not uncommon at all. In a survey of over 1,000 people in BC who are receiving medications through the drug treatment program, about half of them had at least some manifestations of lipid dystrophy, so fat gain and or fat loss. So this was a common issue, and again was associated with other problems such as high cholesterol and triglycerides, which, as you're probably aware, can be associated with serious outcomes like heart disease and stroke, etc. And in fact, in this very large international study that was done in the early 2000s, it showed that the incidence of myocardial infarction or heart attack increased by 16% with every year of treatment with the antiretrovirals in use at the time. And this is a large study with almost 100,000 person years of follow-up time. So a very solid sort of association. Putting that another way, taking antiretroviral therapy for 5 years or more would double your risk of having a heart attack. So this is a non-trivial problem in association with the antiretrovirals. Another issue which Sylvia and I studied was bone loss or osteoporosis. And this is a situation where the bones become weak and susceptible to fractures. And usually it's only an issue in older women past the menopausal period. But during the early 2000s, Sylvia and I did a survey of about 300 people in our clinic, the majority of whom were men in their 40s, and found that 20% of them, or 1 in 5, already had lower than expected bone mineral density, which was much, much higher than you would expect to see in a relatively young population of men. So with all these both short and long-term side effects to contend with and the large number of pills that we were asking people to take, a lot of people thought, oh, maybe we should give people a holiday from taking drugs. And Sylvia touched on this as well, this concept of intermittent therapy. So the idea was to, because these drugs are toxic, let's reduce people's exposure to them, which secondarily would also decrease the cost of them, and yet maintain the CD4 in a good range so people don't develop AIDS. And this idea was put forward by a number of groups, including the now famous Tony Fauci, who did a pilot study of 10 people living with HIV, trying out this kind of intermittent therapy, and it seemed to be a pretty good idea. So as a result of that, a very much larger randomized controlled trial was done called the SMART study, which stands for Strategies in Management of Antiretroviral Therapy. And in this study, over 5,000 people were randomly assigned to either receive continuous antiretroviral therapy, so that's shown in the panel on the right-hand side. This would suppress the viral load down to undetectable levels and maintain the CD4 at a consistent level. Or they would receive intermittent antiviral therapy, so they would take antiviral therapy, suppressing their viral load and raising the CD4 cell count up, and then they'd take a break from it, and when that happened, the viral load would spike up, the CD4 cell count would drop down, and then they started again, etc. So this strategy was called CD4-guided antiviral therapy. And somewhat surprisingly, perhaps, what they actually found was this interrupted therapy strategy significantly increased the risk not only of AIDS-related infections, but also other types of conditions that were not thought to be related to AIDS, such as heart disease, kidney disease, liver disease, and death from any cause. All of those things were more common in the people taking antiviral therapy. And in fact, and sort of discouragingly, the intermittent therapy did not reduce the risk of side effects and adverse events that were thought to be associated with antiviral therapy. And so probably a lot of those issues were not being caused by the antivirals themselves, but were being caused by the inflammation caused by chronic viral replication in someone with chronic HIV infection. So by far the better strategy clearly is to be on continuous antiviral therapy, suppressing the viral load. And after the results of this study came out, this intermittent therapy strategy was abandoned. So just in very quick summary then, in the 10 or so years after the 1996 Vancouver AIDS conference, we have good treatments that can suppress viral load, keep people healthy, improve their life expectancy, and decrease the rate of AIDS-defining illnesses. On the other hand, we're asking for a lot from our patients in having to take a lot of pills, often frequently, drinking 2 liters of water a day, etc., and also having numerous potential side effects, thus really having a significant burden on their quality of life. So just in conclusion, and looking forward to having a chat now, I really want to thank all the people who have participated in studies, both then and now. Clearly, we're standing on your shoulders in terms of the knowledge that we've gained from research. And of course, many, many thanks to Dr. Montana and all of my colleagues at the Center for Excellence that I've had the pleasure of working with for almost 30 years, close to 30. So thanks very much.
Well, thank you, Marianne. So I will remind the audience that they are quite welcome to enter questions in the chat box while we start our discussion. And we're trying to switch the cameras over, but I'm supposed to get a little message that's not there. So, yeah, it's okay. I think as long as, can you do it from that one? Yeah, I think we're good. I think we're going to do that. So while the IT team is working on that, I think we can start our discussion anyways. And maybe I will start with you, Sylvia, because I know that there were many initiatives that we can talk about, but why don't we talk a little bit about some of the initiatives that were started by the BC-CfE to enhance patient care with respect to education, centralized care. So I'm sort of referring to the John Rudy Clinic, and education, as many of you may know, that Dr. Guillemie led the education team for many years. So I will ask you to reflect on that. Yeah.
So yeah, as you may remember or not, but back I think was in the early 2000s, we working with a group at the CFE at the time. Dr. Mike O'Shaughnessy was the lead, but certainly with the support of Dr. Montana and others, we redeveloped what at the time was the IDC. The IDC back then was mostly a research-oriented clinic. There were few family doctors that would come, but we realized, we did a bit of a needs assessment, and we realized that there was a need for centers that will provide primary care focus focus on the primary aspects of HIV, particularly a comprehensive approach with multidisciplinary access to multidisciplinary care, and with the support also of the PHC group, the IDC was developed and was started in 2003, if I'm not wrong. Mm-hmm. Dr. Barrios then joined us later and also improved the whole project. It's been a very successful project. Now it's called the GRC, John Rudy Clinic, because as you know, John Rudy was one of the first people starting with this. He was the head of internal medicine here at St. Paul's. He's now, as far as I know, in Halifax. Mm-hmm. Many people don't know that, why the John Rudy Clinic. So that very quickly patients started to come, and is now providing very good service for the community, particularly here in the West End, with other partners that been working with us. So once this was developed, we also understood that there was a need to provide clinical education to primary care providers. So we wanted to also use this huge resource where there were family physicians that were trained in HIV, as well as specialists that were coming to the clinic to train other family physicians and later nurse practitioners that also were interested in this. So that's how the clinical education program developed the intensive preceptorship, and as well we work closely with UBC in the R3 program, or the Enhanced Skills programs, to train physicians for 3 months or so. And that again turned out to be very successful. People were interesting because we wanted to increase the capacity across the province for individuals to access care. So we had physicians and nurse practitioners trained from all over the province. And that was also coincidental with the Stop HIV initiative. We knew that we needed to test more and treat more. So there was that, we identified that need of training more care providers.
Yeah, I think so. I think that what you highlight is that it was really a unique concept to decentralize the care of HIV, because really so many of the early research studies and the early care was focused on just a few individuals who'd done specialized training or who had particular expertise in treating HIV, but we realized that the benefit of the patients would be to give their care closer to home and to facilitate greater knowledge province-wide. So I think that you have to be commended for that effort. It was
Thank
very
you.
successful. It's made a huge change in the way that we treat HIV in this province, and I hope has been a benefit to the patients themselves. So.
And continues to be under your supervision now. Yeah, there we go.
There. So, okay, well, how about, let's talk a little bit more about the treatments themselves. And I think that you both sort of touched on this, but I think it's worth just reflecting a little bit more about how challenging it really was for the patients to take these treatments and how much knowledge was really in evolution about how difficult it was for the patients and the many side effects that there were for the patients. So I suppose, could you think about, again, Sylvia or Marianne, either of you, were the people living with HIV, were they resistant to take the medication? Like, was there a certain point where you were balancing trying to treat the HIV and trying to treat the side effects, and how did you approach that? How, like, what sort of things do you remember were helpful in trying to guide people through that difficult time?
Yeah, thanks, Val. Excellent question. Certainly early on, people were just so thankful to have something that they could take that, you know, had been shown to be helpful. And many of them had been through the sort of horrific AZT monotherapy era where they took zidovudine, and for those of you who weren't around then, when it first came out, we thought you had to take it every 4 hours. So people were literally setting their alarms, waking up at 2 a.m., taking a handful of pills, and we gave it in very high doses, and it caused miserable side effects. And then on top of that, you know, it really didn't work all that well. So a lot of them were very thankful to have something that had been shown to be effective, that they didn't have to get up in the middle of the night to take, although some of the regimens were pretty inconvenient. And so just Antiviral, I've mentioned a couple of times, not only did you have to drink a lot of water with it, but you had to take it every 8 hours, not 3 times a day, but every 8 hours. Handful of pills. You couldn't take it with food, so you had to take it on an empty stomach, and then you had to take your other medications at a separate time. So even if people were on what sounds like a fairly simple 3 times daily regimen, it wasn't really 3 times daily. It was, you know, they were taking pills every time they turned around. But as I said, initially people were pretty happy to do that. But certainly in terms of the side effects, what happened, as you alluded to, was sometimes they would get side effects like high cholesterol or something, and then we had to give them more medicines to treat those side effects. So not only were they taking all the antivirals, but they're taking additional medications, and then, you know, experiencing the side effects from those medications, and sometimes interactions between the other medications and their antivirals. So it became very, very complicated, both for treaters and of course for the patients. Fortunately now, the medications that we have fewer side effects, and also if someone has an adverse side effect, we usually can switch them off the drug to something else because we have lots of options. But back then there weren't a lot of options, you know, so this is what we have that works, so you have to take all these other pills along with it. So it was a challenging time.
Yeah, so to add on that, I agree with Marianne, and, you know, patients were very motivated, and it was amazing how much they knew and how much support they have also within their own community. Again, I take my hat to the organizations that were supporting, like PWA at the time and AIDS Vancouver. And here at the centers as well, and the clinic, we have so much help from different disciplines to help with that. Dietitians or specialists like kidney specialists, or, you know, endocrinologists, skin doctors. So that model of the interdisciplinary care helped to support these patients through their journey. Some may have or stopped treatments and unfortunately have very poor outcomes. Others managed to sail through that, and now they're in a better place because they, as Marianne says, we have better tolerated drugs. Yeah.
And I think it's really, I agree, and I think it's really worth reflecting too and acknowledging that it was difficult for them, and they also showed real courage, real determination, real patience as we learned as they came to us and said, this is happening, and we said, oh, well, you know, you're gaining weight. That's better than being so underweight that you don't have energy to move, you don't have energy to do anything. And then as we learned that, oh, this type of weight gain, this lipodystrophy is not good, it's not normal, there's something bad about it. So I think, again, just to acknowledge that too, as part of the journey has been, is really important.
Teamwork.
Yeah, real teamwork, including the patients. Yeah, exactly. Okay, so we do have some comments in the chat box, some questions. Some of them really are comments regarding other people of the team who remember being here during that time. So no crying. So I'm not going to get into those too many times. But there is a comment here from Dr. Pick, who, as many of you know, was one of our infectious disease HIV specialists who works at the BC Center, or at the BC Women's Hospital at the Oak Tree Clinic that specializes in care for women and pregnant women. And she does bring up a really poignant point that one of the things that changed is that initially HIV positive women were recommended to not get pregnant or to abort if they were pregnant due to the lack of knowledge of HIV vertical transmission and how best to manage that. And now that's completely changed, and we know that if women take antiretrovirals after the first 4 weeks of pregnancy and are undetectable at delivery, that the risk of transmission is less than 1%. So really a remarkable change with the advent of antiretroviral therapy, and it does bear, it is important to recognize, first of all, the tragedy that was involved with the early days without that knowledge, and now the advances that have been made. So thank you, Dr. Pick, for that comment. Now, how about, again, I'll give this to either of you. Do you have any special stories you'd like to share? Any particular patients without any identifying factors, obviously, who either struggled to take the treatment and then managed to overcome that, and what you remember about that time, or instead whether there were any other initiatives that you remember being very important to you in sort of managing your treatment, your patients. But let's focus first on if there's any sort of personal stories that you remember.
I do remember a few. I mean, there are certainly the earlier ones are the hardest one, and those patients that, as we were discussing, either they didn't take treatments because they were having tolerability or the treatments were not working, and eventually, unfortunately, they pass away due to that. And was doing primary care at the time. I was in a little office across the street, and I used to see a lot of patients with AIDS, and that was really heartbreaking. One story that always stick with me is also a bit related, although I told you I wasn't going to talk about stigma, but a bit related to that. And this is a woman that I met actually in the Bridge Clinic at the time. Now it doesn't work, it's not here anymore. She was coming from a Latin American country, just not to give identifiers. And she was diagnosed to be HIV positive at the time that she was pregnant, as part of her pregnancy assessment, just going back to a little bit of what Neora was talking about. And that was devastating. This was her third child. The story was complicated. Eventually, she had a successful outcome. The kid was born. But she told me, when we were talking about adherence and taking the medications, she explained to me that she actually was taking the medications in the closet in her bedroom, so her kids and her family wouldn't see her taking the medications. She take them, and until now she's doing very well, and it's amazing. But at the time, the stigma was so strong that.
Wow.
See, tissues,
Yeah.
tissues.
That's awful.
But
Really tough, yeah.
And I think probably that still might happen, or may in some aspects of this. I think for some people from different cultures, from different backgrounds, diagnosis of HIV is quite devastating. But that was a story that stuck with me.
Yeah, I remember similar issues with patients because some of our medications had to be refrigerated, and we had to choose sometimes ones that didn't have to be refrigerated so that they wouldn't be in the family refrigerator, because again, they were hiding the medications and hiding that information from their family. Yeah, so that we couldn't give them, for example, the ritonavir that I remember had to be in the fridge.
Exactly.
Yeah, yeah. Yeah, really difficult. I can't remember now which of you spoke about it, but I thought maybe we could just touch on, again, the strengths of the center that really seemed to add to the success during this period. And one of the ones I wanted to just kind of tease out a little bit was really the centralized drug treatment program and the centralized laboratory services. Because I know, Sylvia, you sort of mentioned we're special, we have this, but what did it mean? What did it mean at that time? What does that meant to your ability to treat HIV?
Well, it's huge. You know, the fact that I don't need to ask the patients what type of healthcare coverage they have. Do you have extended health or not? I mean, anybody has access to treatment, and that's super important. And now, I think we talk a little bit about it. We're starting treatment immediately. So even with Dr. Hall, we treat patients that are diagnosed today, and they start treatment today. And we have access to the lab immediately. We have access to the virology lab, which is amazing. That's here. Many times we call our colleagues at the virology lab and say, oh, can you tell me about this resistance test? How can we interpret that? So there is, the whole infrastructure and the ability to provide antiretroviral therapy, no questions asked, is an amazing privilege, I would say, that we have here. Now, not too many people realize that. Even just going from province to province, the whole thing is totally different. And patients, when they're moving away from BC, I sort of always tell them, if you're moving, you better watch out, how your coverage is or what's going to happen, because it's not the same. It's not the same that here, right? Yeah.
Excellent.
Yeah, and I started out doing my HIV work back in the early 1990s in Montreal, and not to point a finger at Quebec at all, because that's just the place that I had experience with. And there are lots of very smart doctors and healthcare professionals in Montreal who are just as smart and just as dedicated to treating HIV. But the thing was there that the care was very siloed, and it wasn't across language lines. It was different clinics, had their own little thing going, different clinics in different hospitals. Whereas when I came here and everything, the focus and the vision was so centralized out of Vancouver, that it works so much better in so many ways. And that was within Montreal, let alone what happened in the rest of Quebec and the rural parts of the province and so on. But it was just very disjointed and very sort of inefficient. And from my experience with other provinces, it was kind of similar. And BC's system was really, and remains, I think, pretty unique.
Do you think that there were, where you're saying, sort of, you're just mentioning, or at least what I heard there was that it was really best to be sort of centralized and close to the clinic here. We talked about trying to decentralize care, but certainly there was a period of time where I feel like there were some patients who maybe didn't have the same access to care. Were there any particular patient groups that you can think of that maybe weren't as well able to access care?
Certainly in terms of the early experimental therapies in the clinical trials, that was an issue, because for a number of very practical and reasonable reasons, you had to physically see patients who were involved in clinical trials, which meant that they were pretty limited to people who were living in the Lower Mainland. And that was not just sort of an administrative bureaucratic type of thing, but really for people's safety, because the drugs were experimental, which means not only we didn't know how well they worked, but we didn't know what their how safe they were and what their side effects may be, so that if someone was receiving an experimental drug and they had a side effect, they had to be nearby so we could see them and assess them properly and so on. So certainly in terms of access to experimental drugs, that was unfortunately really limited, geographically, depending where you lived in the province. Fortunately, once the drugs then went on to get approved by Health Canada and went on the center's formulary, then one hopes that the drug access is spread throughout the province in a more equitable fashion.
Yeah, and I believe that in general happens. People in different parts of the province have equal or relatively equal access, maybe not as expedited as we do here in the Ivory Tower in St. Paul's, but this brings me also brings the point of the role of our pharmacists. We didn't mention that, but the pharmacists at St. Paul's are amazing. We have a great team of people that have been they're very quick in responding to the needs of patients around the province. They will connect with their doctors somewhere else in the north or wherever they are and send the medications as soon as possible. So even during the COVID time, we bent over to make sure that everybody accessed treatment immediately.
And the floods.
And the floods. And there have been a lot of, and the pharmacies, at St. Paul's and the centers have been excellent in responding to that.
I think we've sort of touched on this, but we haven't really highlighted it yet, but I think it will be coming up in future sessions. But it's interesting to think about how much things have changed in the last 30 years from going, from BC being the epicenter of HIV infection to now being a world recognized guide in treating HIV and preventing HIV. So you mentioned treatment as prevention and being on antiretroviral therapy to sort of to decrease the likelihood of transmission. But if you had to, again, reflect on how did we get here? Like what? I mean, it's such a shocking and amazing change, right? So I don't know that you could really tease out one individual thing, but it has been, if you think about it like that, a remarkable journey, right?
Mm-hmm. And I think it's the work of a team of people. Of course, we both thank Julio for his leadership. He's a visionary in that way. He had a huge influence, even internationally with all his initiatives. And again, wonderful the virology lab that's been working here, all the epidemiologies, all the, so many aspects to the program that really makes it very comprehensive and I think provides information to move things forward.
And yeah, teamwork is really the key. It's not one person or one group of people. It's a large group of people working for, towards a common cause. And yeah, there was a time there when things were changing so rapidly, like such a, things were just moving along so quickly. There was a while there where there were HIV or AIDS specialty or subspecialty conferences, literally a month, like 2 a month. And I used to do a lot of traveling then and almost had a divorce because I was away so much, because you could go to an HIV conference every 2 weeks.
Everywhere in the world.
And sometimes you sort of had to stay up to date with what was happening because things just changed so quickly. And because, I think partly because of the system we have being relatively centralized in BC, we were able to then incorporate those changes very quickly into our system. So that was a big part of it.
I think we're almost out of time, but I'll just acknowledge there is one more question in the chat that I personally don't think I can answer, but maybe one of you can. But the question is really relating to whether any of us have had experience working with children living with HIV. And I have to say, I think this will have to be one of a chapter for a next discussion. But if either of you did have any experience with that, or any families living with HIV, and what that might have been like.
I personally don't, because as you know, the team of O3 Clinic takes care of them. But one of the things we needed to highlight is we hardly have any new children diagnosed with HIV in BC, thanks to the treatments that we have. But some of those that were infected earlier in the era now are teenagers or grown adults. Mm-hmm. And I know the transition from being taking care of the O3, where they were so well taken care of, to the communities and to other organizations was kind of difficult and traumatic. So we've been working with them, helping to transition these young adults into the communities and to receive care either at GRC or other places.
Yeah, so I do look forward. We will have to have another session with some of our care providers that specialize with in HIV in pregnant women and children. So I think that will be important. So with that, I actually think that we will be drawing our discussion to a close. Just want to thank both of you for joining us today and making me remember those hectic and sort of heady times where things were changing so quickly we could barely keep up. And again, just really acknowledge and thank the people who were living with HIV for being patient with us, because we were learning as we were going and we were doing our best, but it was a difficult, challenging time, and definitely we acknowledge that the treatments we offered weren't perfect, but with time, they certainly have improved, and we look forward to having another one of these discussions in the fall. I think that we're hoping for another chapter of our conversation series in September, and we haven't quite decided the content of all of them, but it's sounding like women and children might be an important next subject. So again, thank you to Dr. Pick for her comment earlier, and thank you all of you for joining us today, and look forward to seeing you in September.